Thank you, everybody. Thank you so much for having me here today. It's great to see this group here together. Unfortunately, I'm going to be here talking to you about this Debbie Downer topic, workplace violence, right? And then to top it off, they give me the big ask of throwing research on top of that. And so we sit here and we go like, wow, how much awful can they make this topic for me? And I was like, actually though, I kind of view this combination of topics of workplace violence and research as like this tree. To me, I look at that tree, it looks like he's happy and he's smiling, right? And other people in the room are going, that's a monster, right? That's a monster. Well, if you're a little fearful here of talking about research, bear with me, okay? Bear with me. I promise it won't be so bad. Now, when we're talking though about workplace violence, I need you to understand and be in an okay place with this topic, because I know there are people in this room who's had some significant events in their professional career with workplace violence. Okay, and I don't know about you, but when I went into nursing, this was not on my radar. I did not know that this was a real thing for healthcare, for nurses. All right, and so I don't know, I have to really double check my source here, but I really don't even think workplace violence is taught in school, right? Or about how to de-escalate, and I'm really confident it's not on the NCLEX, right? We walked into this career and had no concept of what we were supposed to do with this. So as we go through today's topic here, we've got the next 50-ish minutes to talk about this topic. If you have your personal experience, you're going to relive it, you're going to remember it. We're going to be within this place together as we're talking about this, okay? Now, also when we're talking about it, though, I'm going to present some information that you may not even agree with me, and that's okay. And actually, some of the things I'm going to share with you, I might just make you mad. I might make you mad about this topic. And I'll take that as a win, because you know what? When we're done with this hour, I know I've made you think. I know I've made you think about it, maybe in a different way, okay? So, why workplace violence, though? All right? The Joint Commission, as of this year, started and initiated some new requirements. And Magnet, if you work at a Magnet organization, has some new requirements. Press Ganey and NDNQI has been tracking actually different types of workplace violence for a couple of years. And now even politicians are getting involved to sit there and go, what can we do to make healthcare workers' lives better? Okay, and I'm not going to get into the regulations, regulatory politics of this, because that would be boring. I want to talk about a little different stuff, but it's on everybody's radar because it's a huge issue. How big? How big of an issue is this? Well, this is a global problem. It's a global phenomenon. It's not just here in Colorado or in the United States. It's everywhere, okay? To the point of, there's a systematic review related to workplace violence. This study, the prevalence of workplace violence against healthcare professionals by patients and visitors, a systematic review. Okay, so let's think about just the title. They're looking at just the prevalence of physical workplace violence, and they pare it down and carve out nurses in that study as well. All right, now, what is a systematic review? Now, a systematic review is where this group of incredibly nerdy people got together and they said, let's study all of these studies that we can find about only healthcare workers' workplace violence, only physical violence, and we're going to lay them out all on the table, and we're going to study the studies. We're going to see what all those studies can tell us, all right? And this is a huge systematic review. There are 65 studies that qualified for their inclusion criteria for an N number, a total N number of more than 61,000 nurses were included in this. Okay, huge, huge systematic review. And what did they find in that? That 1 out of 5 nurses experience a physical event every year. Okay, so it's like just physical, not verbal, not being yelled at, not over the phone, not email, a physical abusive situation, all right? 20%, 20%. So if we were to carve out this room, that would be almost like this whole section over here every year. You guys got beat up every year, okay? And it's like, whoa. Now, but I don't know about you, I have a hard time with 20%. That doesn't really seem like a real number to me. So I embrace my own inner nerd, and I'm gonna take some other calculations on this. And I say, okay, the World Health Organization says that there's almost 28 million nurses across the globe, 27.9. So if I take 27.9 and I do 20% on that, that's more than 5.5 million physical events on nurses every year. Take it down even further, that is 15,000 physical abusive events on nurses every day, 637 every hour. 11 nurses have a physical event across the globe every minute. Every minute. So in the time that I've been talking, there have been 55 nurses who have been physically abused since I started talking. This is how big it is. It's a big problem. So what are we taught to do in healthcare? We've got a big problem. Go to the literature, right? You're supposed to go to the literature, see if we can solve this problem, all right? So no matter where you work, you probably have access to PubMed and CINAHL. So let's just stick with that. All right? So the first thing we do is we go to PubMed, okay? And before we do our search term, I'm going to make sure I put workplace violence in quotes, okay? So why do I put that in quotes, though? Because PubMed isn't smart enough. If I tell it just workplace violence and nursing, it's going to search all of workplace. It's going to search all of violence, and then it's going to search all of nursing, and it's going to be kind of a big mess. But I want only workplace violence and nursing. So then I do the same thing for CINAHL. And for those of you who are online, I know you can't really see this very well. All right, so let me blow this up here for you. PubMed, there were 933 results. Okay? Now, for CINAHL, though, 6,400. But, okay, wait a minute. I wasn't comparing apples to apples on that, because if you notice in CINAHL, that's 6,400 of just workplace violence. So let's compare and say workplace violence in nursing, 2,500. Now wait a minute, how can PubMed and CINAHL produce such different results in regards to just looking at the data? Well, these two databases have two distinct personalities. All right? PubMed is very medically focused. It's going to be very provider focused. But then CINAHL, what does CINAHL stand for? Cumulative Index of Allied Health and Nursing Literature. Okay, not very sexy. Everybody says CINAHL, all right? So it's nursing and allied health. So it's just nursing specific, all right? So that's why there are different polls, different results for these two data sets. Okay, but that gives you a flavor of how much information is out there about this gigantic topic. Do you think we could be able to find our answer in looking at all of these articles? That would even make me googly-eyed. Well, what's part of the problem with this? I'm going to ask you a really basic question. What is workplace violence? What is workplace violence? I mean, you can, like these trees, you look up and it's going to make you dizzy because it's just going to be all over the place. All right, and if I were to ask each one of you as you walked into this room what it is, I know I'd get a myriad of different answers. All right, and if you go to the literature, the number one thing that you're going to come across, it's going to say in many studies, there is a lack of a universal definition. Really? Really? All right, well, let's talk about that then. What is workplace violence? Well, there is the first article that we have listed here is called a concept analysis. Now, what is a concept analysis? And that is an article and a study that tries to address and answer that very question. And it has a structured format, and it's going to provide an understanding of what concept is of workplace violence. And they do that by aligning and assigning and explaining what an attribute, an antecedent, and a consequence is. Now, an attribute means what are all the pieces of this problem that you have to have in order to have a workplace violence event? Well, you have to have a staff member, and you have to have a perpetrator. Okay, that's not very helpful, but what's an antecedent? What leads up to the event? Well, you have these two parties, and they don't agree. So what's the consequence? We have a workplace violent event. Okay, so for you as a practicing clinician, does that answer your question for you about what is workplace violence? Doesn't me. Doesn't me. So what is workplace violence? Now, the World Health Organization, has global emphasis. They came up with a definition. I actually like this definition. Incidents where staff are abused, threatened, or assaulted in circumstances related to their work, involving an explicit or implicit challenge to their personal well-being, safety, or health. I like that definition, okay? Now, what's interesting about this definition, though, is that that is just a very small snippet of the actual World Health Organization definition, because their definition is actually a manual, and it's 35 pages long. Okay, so what they try to do with their definition is they break it up based upon whether there's a physical event, a psychological event, or a sexual event. All right? And what they try to do is they try to say, okay, if there's a physical event, we're going to describe everything that could possibly happen. Pushing, pulling, stabbing, twisting, like everything. And they come up with every verb and adjective that they can find. Do you think maybe they missed one? Is it possible? Always. So I read a lot of workplace violence reports. And one of them came up as like exhaling. Could exhaling be a workplace violent event? So true case. A nurse went into a patient's room, and the patient and the visitor had locked themselves in the bathroom. So went and got the key, unlocked the door, opened it, and when the nurse opened up the door, got hit with this wave of a white smoke, malodorous, that made her feel dizzy, sleepy at the time of exposure. The report didn't say she got the munchies too, but we can guess, okay? But it was so significant that she had to go home. Really? Now, was that exhaling event, did it challenge her safety and well-being and health? Yeah. And that was pre-COVID, right? Do you think COVID in the state, like exhaling, could be a workplace violent event? Yeah. Heck yeah. So that's the World Health Organization. But here in the US, we have OSHA. OSHA has their own explanation and own definition of workplace violence. Okay, and what they say is it's any act or threat of physical violence, harassment, intimidation, or other threatening disruptive behavior that occurs at the work site. Okay, now this is the definition that's embraced here in the US, and the CDC uses it, the ANA uses it, the Emergency Nurses Association, and yes, even our beloved ONS uses a variation of this definition, okay? So the difference here, though, is that with the OSHA definition, this is about it. It's very simplistic. They just say, any event, done. Don't even try to explain it. But what they do try to explain is, who's the perpetrator? Who's the perp? Well, let's talk about that, all right? Because OSHA divides it up based upon the perpetrator in 4 types. Type 1. Type 1 is the perpetrator is unknown to the staff or the organization, but they can trigger an event. What? That is where you're on your shift and you're doing your work and you come back to your car and somebody had broken into your car, slashed your tires or something. That was a criminal event that created a workplace violent event, but they were unknown to you, not known to the organization. Okay, so that is a type 1 event. Type 2 is the one we are all way too familiar with. It's the patient or visitor as the perp, okay? But type 3 is a colleague. Now, we don't often call type 3. We call it bullying, mobbing, lateral violence, horizontal violence, okay? But that is colleague to colleague, okay? Now, there's also a type 4. In my estimation, in my opinion, this is the most least understood form of workplace violence. That's where the perpetrator is actually known to the employee, but they're not known to the organization. What does that mean? Okay, tough example, an ex-spouse comes onto the work, and they're known to the employee to harm the employee because they know where the employee is. They know when they work, all right? So that is type 4. So this is how OSHA divides it up. But again, I ask you, has this explained to you what is workplace violence? What is it? What is it? So let's take a minute and let's pause, okay? Now, as we've been sitting here talking, I'm sure some of you have had some of your events and, memories kind of popping up and it's like, oh yeah, some of my personal experiences. I'm gonna tell you a story. I was in the grocery store, and I'm sitting there minding my own business, waiting to be checked out, and the people in front of me, the man, starts picking up his groceries, and he's throwing it at the checker. And the checker's like, oh my gosh, I have no idea where this came from. What triggered this? And the wife, could have been wife, I don't know. The lady who was with the guy was like, I don't even know why we come here anymore. These people are pathetic. They're useless and they're stupid. I don't even know why we're here. I'm like, oh my gosh. People are COVID crazy, that's what I say. People are COVID crazy. Now, gut check. Take a minute. What is your response to that story? I saw faces of incredulous, disbelief, astounded. Are you kidding me? All right, now this is where I'm going to beg your forgiveness and say, I started that out by saying, I'm going to tell you a story that really didn't happen to me in the grocery store. That happened to my oncology nurse colleagues. That happened to my oncology nurse colleagues. So why is it, here's my challenge to you, why is it I tell you that this happened in the grocery store and everybody's like, oh, but if I tell you this happened out on the floor, this happened in the clinic, what's your reaction then? And you're like, oh, wow, what's the difference? What's the difference? Okay? So that's my challenge for you right now. I want you to pay attention to that. As we continue to talk about workplace violence, where's your thinking? Where's your heart? All right? What is workplace violence? Now, I'm going to challenge you again and say, it is whatever you say it is. We have these definitions, but it's whatever you say it is. You have a moment where you're upset, unbelief, disbelief. That hurt. That was icky. I don't like that. That did not make me feel good. That was personally demeaning to me. That's an event. All right? Now just think about it. We acknowledge a patient's pain to whatever they say it is, right? So what about us? Can we acknowledge workplace violence based upon whatever we say it is? So, what is it? Workplace violence comes in a whole bunch of different colors. So let's talk about those. Again, because I only have, less than an hour, I am only gonna focus in on here patient and visitor perpetrated workplace violence in oncology, okay? Let me try and keep it narrow. So, of course, as is the World Health Organization says, we have physical violence. It's kind of a elephant in the room, gimme. We've got verbal violence. We've got sexual violence. Those are the Captain Obvious ones, all right? But let's talk about some other not so obvious things. What about social issue-related workplace violence? Racial violence? I actually happened to work with a lady who was born in Uganda. She's a fabulous nurse, okay? And she works in a clinic, and she does a lot of her patient care over the phone, right? People can't even see her, all right? But she was born in Uganda. It's her primary language. She sounds different over the phone. She is the target of racial workplace violence. We also have a religious focus. Somebody might wear a headscarf, religious medallions, makes them a target. Gender issues. Now, I'm sure some of you worked on the floor, and where you have signs on there that says, men, don't go in, or women, don't go in. This patient doesn't respond well, all right? And that's just based upon gender. But what about gender non-conforming situations? Very much of target, all right? But let's also talk about the telephone. Telephone. All right, my nurse navigator colleagues out here, care coordinators, you guys spend a lot of time on the phone. All right, and it's like, how many awful things have people said to you on the phone? Unbelievable. Unbelievable. Let alone then email. No kidding. There is this social distance between phone and email that people might not even say something quite so egregious to your face, but when there's just that little bit of a distance, whoa, it's shocking. All right? Then there's psychological workplace violence. And you're like, what the heck is that? One of my best examples is stalking. Oh, stalking. So, nobody's yelling at you, nobody's physically threatening you, nobody's hurt you. But people have been followed to their car, followed home, followed on Facebook, stalked on Facebook. Creepy, creepy, right? So that gives you definitely a sense of insecurity, but there's another form of workplace violence that I believe is terribly under-recognized that I want to bring onto the table. Secondary trauma, okay? I may not have been the target of the event, but my oncology nurse colleague, Jennifer, was smacked. Really wasn't that hard, but it broke her glasses and cut her face. So I had to help her, take her down to the ED to get her some treatment and get stitches, call her husband, she went home. She's not really terribly hurt, but hurt enough. So then I have to go back up to the unit. I cover her the rest of her shift. And I go home. Oh, I notice a little bit of her blood on my scrubs. You think I'm not impacted by all of that? Absolutely. Secondary trauma. Secondary trauma. There's also near misses. Near misses. Just because somebody took a swing at you and they missed, oh, lucky you? No. I know, I talked to a nurse that worked in the ED that one of the patients, out of their mind, actually ripped the TV out of the wall, bracket and everything, and threw it at the nurse. Okay, it's a gigantic TV. The nurse was able to dodge the TV, thank goodness. Oh my gosh. Nurse was not hurt. The nurse was laughing. I'm like, oh my gosh. Did you file a report? No. Why would I file a report? I wasn't hurt. You had a TV thrown at you. Okay. They're like, incredible. So near misses. And if you feel like COVID has made a difference in regards to workplace violence, Oh yeah, we've got the proof, okay? So when did COVID start getting crazy here? 2020, right? Well, look at that. We have our first study kind of came out that said, hey people, Lancet put out an article that said, okay, COVID's making people go COVID crazy. Do you feel it? We think we feel it. Do you see it? The end result of that article in 2020 by Lancet was saying, oh my gosh, somebody needs to study this. Okay, you're like, okay, great. So in 2021, there's a violence against healthcare workers during the COVID-19 pandemic, a review of the incidents from a lower middle income country. It was actually based in Pakistan. So, and you go, why there? Okay, again, remember, workplace violence is a global phenomenon, right? And Pakistan actually has an extensive amount of data that they produce related to workplace violence. So they had a ton of pre-data. And they could measure then, what has COVID done in Pakistan? And they found, ooh, big difference. Yes, pre-post, we've got big difference, all right? Then we have the last study, just came out, in an academic ED that said, yeah, we've got big numbers and we have statistical significance, that there is a big difference between people being pre-COVID and post-COVID, okay? So to me, I call it COVID crazy. People are COVID crazy, all right? So, but you can watch how the data has kind of progressed and grown at, with this new phenomenon. But I want you to also think about, in your experience, the location of workplace violence events. All right, so inpatient nurses, they get a lot of attention, all right? That's where it really kind of becomes starts in the people's thinking. But for those of you who work in a clinic, those of you who work in home care, on the phone, in email, there's a difference between the workplace violence and inpatient and what you see in some of these other outlying areas. And I can tell you the number one difference is that in the clinics, in home care, in the phone, and email, people are lucid. They know exactly what they're saying. They're trying to hurt you. Okay, that makes it a little tougher, right? So you have an inpatient person they're there because they're really sick, right? It's easier to kind of wrap your head around that. But if you're in a clinic and somebody's losing it at your face, ooh, that hurts. That hurts even more. Now, I will tell you that I started my nursing career out in home care, all right? I was an oncology nurse, and then I started doing home care visits. And when I was a young nurse, I was told that you are a guest in the patient's home, all right? And you have the comportment of you are a guest in their home, all right? And so when here I am, a young nurse, and I'm in the patient's home, and I walk in, and the man has porn on the TV. Really? I can't say anything because I'm a guest in their home, right? No, icky, icky, icky. Because if you think about it, that is my workplace. It is my workplace, right? And that's not okay. Nowadays, we have the right to go, no, this is not okay. Please shut that off, right? So, for those of you in all these different locations, we have a qualitative study here that came up with this quote. And I think no matter where you work, you can somewhat relate to this quote, all right? You have to go in there and you think, I can do this. I will do it as quickly and smoothly as possible, and I'm just gonna get out of there, all right? And you can relate to that, whether you're on the phone and you're looking at the phone number going, I gotta call you back. I'm gonna do it, and I'm gonna get off the phone as fast as I can, and then I'm not calling you again until I'm darn good and ready, right? So inpatient nurses, can you relate to that? I am not going in there until I'm gonna cluster my care, right? So here it is, it's a qualitative quote and a qualitative study that is not supposed to be generalizable, and it's not supposed to be applicable to all these different settings, but it is, right? A lot of people can relate to that, and that is the strength of this like qualitative study. It's probably kind of interesting. So location of event for a workplace violent event really matters. But there's another thing that we kind of already alluded to, patient intent. Workplace violence and patient intent, all right? Now, for oncology nurses, this is a big thing. I'm challenging you in your thinking right now. In your experience, how many times have you made excuses for this, for the patients related to this? Oh, the patient didn't mean to. They're really sick. They've got brain mets. They're on neurotoxic chemos, all right? They're under a lot of stress. The patient's dying. Okay. Why does that make it okay? Why is that any different than the grocery store? All right? It's still an event to you. You still had an event. Excuse or not, patient intent or not. All right? Now I made you mad. I told you I was going to make you mad. As I sit there and challenge your thinking, you're like, oh, you're treading into some serious, like, this is oncology sphere. This is oncology. Don't tread on me here. Here's a quote. I'm reluctant to complete an assault incident report. I will not fill out an assault incident paperwork. The patients are sick and they may not know what they're doing, and this is the reason for their hospitalization. That staff should be able to work with them and speak to them with compassion and a respectful tone of voice. Okay, now this quote made me mad. Hey, did you just should on me? You should be able to manage this. Well, you know what? When I was a nursing student, I had a patient completely unprovoked. I'm trying to like arrange her in bed, and she clocked me right in the face. Totally unprovoked. And just like, whoa, where did that come from? Should I have been able to manage that and talk to her in a, tone of voice? I didn't even know it was coming, right? So let's not judge each other, with some of these situations, okay? Let's support each other. Another thing I've already alerted to is the severity of the injury, all right? Just because there was a near miss, just because nobody, I got yelled at on the phone, I don't have a bruise. But the problem with these verbal and constant little things is that with each incident, each demeaning comment, it's a bite out of your soul, okay? And the more those situations happen, it increases the frequency of the verbal abuses that you have. It increases your stress and your intent to leave the profession, all right? And why? Again, why are verbal events so difficult? And it's because they're lucid. They know exactly what they're saying, regardless of whether they're stressed. Okay? And that's what hurts. I've just read a study too, just talking about how it demeans me as a professional. Okay? And it's really hard to deal with these types of verbal events. Okay? There's also a big impact of fear around workplace violence. Well, duh. But it's not just fear from the perpetrator. Okay? It's not just fear from the perpetrator. It's fear from being blamed for the event by my colleague. It's fear of losing my job. It's fear of getting a bad evaluation. Because I can tell you in our organization, before we changed the reporting process, one of the questions on there was, what could you have done differently to keep this from happening? Well, that's subtle, but you're putting the blame on me. Okay, I won't answer the phone. That's how I can prevent it from happening. So we have to recognize and call out that this is a big problem and it's hard. And I'm going to make the leaders in this room now mad, Because I'm going to say, what if we put patients second and we put the staff first, right? If the staff safety is always number one, then maybe our patient care could improve. And I wish I had come up with this idea on my own, but I didn't. Patients come second. This is actually a book written by a chief operations officer for an organization and a business owner who helps hospitals run their patient satisfaction scores. And they wrote this book, and they came up with their own opinion here that said, you know what? You take care of the staff first, then they take care of the patients. So we need to take care of our staff first, right? Okay? And granted, this is an old book. It's actually written in 2013. And it's full of their experiences and their opinions, okay? And you're not going to be able to say, okay, we're going to change our organizational structure based upon patients coming second, but it's a good read. It really makes you think, okay? So that's a thought. Now, time for another gut check, okay? See where you're at. Now that we've talked a little bit more about this, how many of these experiences have you encountered that you wouldn't have considered them as workplace violence? That when you walked in this door, I would have asked you and you said it would have never even been on my radar, okay? How many of these experiences did you negate because it's oncology? But how many of these would you say now, grocery store versus my practice? All right? So, did you report it? Did you report these events? I can tell you, again, I'm embracing my own inner nerd. We're about ready to submit this article. I wrote a systematic review on underreporting of workplace violence events because I know it is such a huge problem in nursing. You don't report. Why? Number one reason across the literature, nothing ever happens from reporting, so I'm not going to report. So that's self-serving, right? If I don't ever report, nothing's going to happen because nothing can happen. If you're a C-suite person, a chief nursing officer, a chief quality officer, a chief whatever officer at your organization, you can't do anything with one report. You need report, 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 and you go, whoa. I think we need to do something about this. Okay? So I am asking you to report. Then also recognize the fear of reporting, fear of patient satisfaction scores, fear of your colleague's judgment. And recognize that this is not just part of the job. Workplace violence is not acceptable. Then we have these other points that we've already talked about. Patient intent, I don't know what to report, because what is workplace violence? Incident wasn't severe enough, don't know how to report, don't have time, don't a lot of things. Underreporting. So it's time, oncology nurses, look in the mirror. I'm asking you to look in the mirror. So when I say, all right, for those of you who might be research nerds like me, where was the oncology data? Well, I went to the literature and said, workplace violence and oncology. The results say 4 studies. There is no data. I can tell you that you could read all 4 of these studies, and 2 of them are related to lateral violence, horizontal violence. Okay, so it's about bullying. It's not even about patient and visitor violence. The other 2 really didn't relate. And if you go to CJON and look up CJON specifically, there's no data. There's articles on workplace violence, but no data. Time to step up to the plate, my oncology nurses, okay? Now, but you're gonna sit there and go, but Cara, I don't have time to do I can't do a research project. I'm up to my eyeballs in patient practice, and I get it, all right? But what I need you to do is 1, recognize where your gut is at. When I have an event, that did not feel good. Think about that. Be aware. Manage that situation. De-escalate sooner. Call in your resources. Pull in your providers. Pull in your leadership. And if you're on the call, what if you hung up? Oh, talk about edgy. Edgy, could you imagine? Okay, but that's what we're asking you to do. And then you turn around and report. Because we need that data in order to make any kind of changes, all right? So when I'm asking you to report, what are you going to report? You're going to report what makes you feel bad because workplace violence is what you say it is, all right? So that's what I'm asking you to do. Also, keep yourself safe. That's the next important thing I need you to do. Patients taking a swing at you and you know they're going to fall, let them fall. I'm telling you, I'm making the leaders mad now too. Okay? So, but in the meantime too, so even report, even if you don't feel like that was all that harmful to me, all right? Report for your colleagues. I can tell you that when I was that home care nurse and I went back to the office, I didn't report the man had porn on the TV. Icky. And unfortunately, the next week, the CNA went out there to give ADLs and help him with a shower. Yes, he tried to sexually assault her. I have to live with that I didn't report. Now, it didn't hurt me to go out there and be in that porn, filled home, but I, by golly, would have reported if I would have known it would help somebody else. And that's what nurses do. You know, the data shows that. Nurses are more likely to report if they're going to protect somebody else than they does for themselves. So, okay, then report even for your colleague, all right, because it's that important, all right? And it's safe to do that, all right? No judgment. I like this quote, too. My coordinator openly defended me in front of me, and I felt really supported by that, and it had a healing effect. Yes, we need to support each other. So here we are, we're wrapping up. Oh, you guys, we talked about research and you don't even know it. Wasn't that fun? So what did we talk about? Okay, well, we talked about workplace violence being a huge top problem, all right? And that there's a lot of data out there, but it's so much data it's hard to grapple with. But there's a lot of data, but there's no data, right? And that's what those gaps in the literature are about. Okay? Then we talked about the difference between a PubMed search and a CINAHL search, all right? And you get different results. So there's value in searching both databases if you can. We talked about concept analysis can help you identify and come up with a definition of a problem, but it didn't fit this one, okay? But we have the attributes, antecedents, and consequences. We also understand the difference between a qualitative study and a quantitative study. Qualitative study is going to be a little bit more stories and the narratives, all right? But a quantitative is going to be those systematic reviews and looking at statistical significance, and it's going to be looking at the numbers. Is one stronger than the other? Not necessarily, but they work together. That's why that one qualitative quote, everybody in the room could kind of relate to, right? Kind of cool. We also know that some things are well studied, some things aren't, like oncology and workplace violence, all right? But some things are going to be new and up and coming. So as we get started with oncology, workplace violence information, it's going to start looking like that COVID. I think we have a problem. Let's start in. Let's get our new data going, okay? And then we also learned that there's levels of evidence. Systematic reviews, we could change our practice based upon systematic reviews, but we wouldn't want to do it based upon a book. We wouldn't, because that's only somebody's opinion. So, as we wrap this up, conclusion, workplace violence is a huge problem, but we are 28 million nurses strong. We can do this together. COVID has shown the world that nursing is vital to healthcare, all right? And that got to start setting our own lines here, guys, okay? 11 physical events every minute. So in the time that now I've talked over my time, but that means almost 600 people have been just physically abused since I've been talking. Okay, oh my gosh. We should be flooding our C-suite organizations, our chief nursing officers, our chief operations officers, our chief quality officers with our reports, verbal reports, email reports, physical events, visitors, colleagues. They need this data. We should be flooding their offices. And you're going to go, wait a minute, Carrie, did you just should on me? Yes, I did. I did just should on you on purpose. Okay? We need this data to be able to move the wheel. So I know this is going to be a tough topic. I started off with that, and if this has brought up some difficult feelings for you, you can Google any of those services to get some additional support if needed. Okay? But thank you so much for having me talk about the workplace violence that clearly I'm passionate about. So, and I could see a lot of faces and a lot of nods in the audience, which kind of sort of almost breaks my heart, because that means you know what I'm talking about. You know what I'm talking about. All right, well, thank you so much. We have questions? We are not supported or properly trained on what is considered workplace violence. Yep. Unless it's physical with injuries, and even then, why report? Nothing happens except the one report gets made to make you feel like you're being blamed, if I understand that correctly. So that's right. What happens is that we have to have together no judgment. You're not being blamed, all right? What could you have done to change that event? And you're like, I didn't do anything, right? I didn't do anything. So you report, and you report, and you report. That's when changes start to occur, all right? And you support each other in that reporting process. As leaders, how do you encourage staff to report near misses? By making sure that everybody recognizes that a near miss is a workplace violent event. Because most of the time, people don't recognize that near misses are an event, right? Just because you were lucky enough to dodge. So what about patients who are known to have psychological issues, or even a patient in a psych hold? Would this be included as workplace violence? Oh, heck yeah. Again, take patient intent off the table. They're sick, but so are the people in ED. So are the people in addiction. So are the seniors who are demented, they have dementia, okay? So all of that, it's still part of workplace violence. Now what happens is that ED and psych, oftentimes they're like, well, we would fill out a report every hour. And I go, uh-huh. And that's part of the problem in organizations. That I know of one facility, they have switched their reporting system over to the phone. So you pull out your phone, you go click, 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 boom, send. That was your report. Now, wouldn't that be nice? All right, and that's how we can really support that as well, okay? Would you consider violence to include when patients participate in staff splitting, manipulation, and or other controlling behaviors? Oh, yeah. Okay, because again, I'm putting it back on you to interpret that, all right? Does that make you feel bad? Does that hurt your processes? Does it interfere with your ability to do your job? Because that's the definitions between the World Health Organization and OSHA. And the answer to that is yes. All right? So that's when you get your behavioral health team, and then that's where you get your team working together. And you go like, okay, they're trying to split us. All right, not gonna do that. So every time you go in, they start doing that, and you go, not going there. I'm not gonna listen to that. You may not speak to me in that tone of voice. You may speak to me respectfully. Or you may speak about my nurse colleague, Barbara, in a respectful tone of voice. I don't want to hear this. Crazy, right? So anyway, these are the questions here. I'm going to be here for a little bit longer. I'm biting into your break time, so I will make sure that I'll stick around here a little bit, so if anybody has any questions or thoughts. But thank you so much.